So this, as you'll see, there's a lot of critical thinking to these two discussions that we're going to have today. The first on medication information, and the next on contrast media, administration. The reason for that is because we kind of exist in a gray area as technologists. There are certain things that we're allowed to do and administer and work with, and there's other things where it's not within our role. We may be asked to do these things, and so defining our role is fairly complicated, right? And so that's why there is this kind of gray area. You may be asked in certain states, for example, in the state of New York, you are not allowed to inject contrast. A nurse has to be in the room, they inject the contrast, and then you initiate the scan, right? Which is kind of nutty if you're trying to do a CT scan, because the nurse doesn't know how to operate the CT scanner, and basically you haven't been trained on how to operate the IV injector. So if something goes wrong with the IV injection, you've got to communicate really quickly with that nurse. Stop the IV injection while I stop the machine, right? So one of those things. And it's also kind of crazy to think that I can't do this exam that I normally could do in any other state without the presence of a nurse, right? In other facilities at other places that I've worked, I've been asked to do things like TB skin tests, ECGs, EKGs, whatever you want to call them. I've been asked to assist with things like the flu vaccine, start IVs for cancer patients, access ports. I've been trained to access ports for medication for chemo. So you, depending on what facility you're working in, you may be asked to do some things that look a lot like what a nurse should be doing, right? Taking vital signs, things like that, right? You've all been trained in some of this stuff. Other things, like for example, accessing a port, that's going to be very specific to that facility. In other facilities, they may have specific policies saying no one other than a chemo nurse should be accessing ports, right? So that's where it becomes very much something that we need to be aware of what the policy is for that institution, what the federal policies are, things like that. So that's our goals for today, is to give us some basic knowledge to make sure that we are comfortable with doing these tasks that we can do, and then defining the roles for tasks where there's a question mark, right? Figuring out what the policies are. So you see right off the bat, describe the radiographer's role in medication administration. Anytime you see those terms, the radiographer's role, know that that's a pretty charged term, right? And it's something it's a political term, it's something that's debated. Even now, like as we speak, there are debates about what the radiographer's role is, for example, in the VA system or in X state, or what is the radiographer's role with this, right? So it's a legal concept, and it's also a professional concept. And we're going to need to explain why those, what certain medications do, right? Because that's part of how we're going to define this role. We're going to need to differentiate between trade names and generic names of medications, talk about using things like drug reference manuals. We'll talk about terms related to how medications work, like efficacy, toxicity, potency. We'll talk about these 4 critical processes that compose pharmacokinetics, and these are important terms that we need to be able to define and also start to think critically about. So if there's a critical thinking component for this lecture, that's it. We're going to talk about different effects that medications can have. We'll talk about different classifications of medications and precautions that we need to exercise for patients who are on any kind of opiate or narcotic, because those can have really important ramifications to how we're taking care of that patient. And then talk about agonists and antagonists. Here's some key terms, and it kind of cut off, but the last one on this list right here is idiosyncratic. But if you see in the textbook, it continues on. Definitely idiosyncratic, though, is one that you definitely want to make a flashcard about, because that's a complicated term that has a lot to do with how contrast interacts inside of people. So we'll be using that term a lot over the next 2 years to describe a fairly complex chemical reaction that we need to understand. All right, so in thinking about the radiographer's role in terms of understanding medication information, there's two things that I would say. First off, a comprehensive knowledge of pharmacology is not essential, right? Well, that's helpful. Like, we don't have to be compounding pharmacists, right, to do what we do. But at the same time, almost like in the same breath to contradict myself, we do need to understand most common drugs and their uses. So I'm saying you don't have to have a comprehensive knowledge, but you need to know a lot of common drugs. You still need to know a lot about drugs, is what I'm saying. So we kind of live in a world of contradiction, if you will. But there's some nice things that will guide us in understanding those contradictions. And maybe the major thing is we need to have basic knowledge of terminology related to medication. We do not necessarily need to know the chemical parts, all that the chemistry is doing. The one exception being the idiosyncratic thing. So the word drugs and medication can be used interchangeably in medicine. So you'll hear me use them interchangeably. When we talk about medications, we'll sometimes use a generic name, which is its actual chemical family. It's a descriptive name of its chemical family, or proprietary trade names. And this is given to a drug by its manufacturer. So you'll hear that, and in the textbook you'll notice generally what it has is like the generic name, and then it might in parentheses have that proprietary name. So we'll look at some examples of that. The resources that we need, and you'll see one of these, a physician's desk reference, kind of at every nursing station in a facility. It now has an app form. You do not need to run out and buy this manual, but you do need to understand that this is an exhaustive kind of dictionary of drugs, right? And so if you ever have questions about a medication, or you're just kind of interested in learning a little bit more about how different medications work, it's a very helpful thing to review. And I don't know, they're easy to find. Okay, two basic properties that we need to be familiar with: pharmacokinetics and pharmacodynamics. Okay, with pharmacokinetics, what we're talking about is the way that the body processes a drug, right? So things like how they're metabolized and then eliminated from the body. This affects how the person's going to respond to the drug, right? And those effects vary according to the individual's age, their physical condition, how healthy they are, their sex, their weight, their immunity status, and a number of other things that could just be called subjective, right? Just like how it makes them feel. An example of that, I remember one time doing an IV contrast injection on a woman, and immediately after the injection, she grabbed my arm and she said, "You have to tell people it makes you feel like you've wet your pants." She was really angry about that. Well, the thing is I don't need to tell people that, because that was unique to you, lady. Like, you're the one person who felt it at that level, right? Some people feel warm. Like, I had an old gentleman say, "You should sell this stuff to ice fishermen." That was his response. Some people feel like they want to party after they had it. Like, one lady was like, "This tastes like crappy tequila." Like, she could taste this crappy tequila taste in her mouth. It may have been from last night. I don't know. But so it affects every person differently, right? All right, pharmacodynamics, right? And this is the study of the effects of the drug on normal physiological functions, right? So it may seem like we're splitting hairs here, but when we're talking about things like the way that interactions vary according to a patient's age, we're talking about pharmacokinetics. With pharmacodynamics, we're talking about the way it affects the physiology of the body. So, for example, I had a manager that I worked with at an undisclosed pizza cafe in Memphis, right, who happened to be a heroin addict, right? And there was an evening when his wife called in and said that he was unresponsive, right? What had happened? Well, it was a pharmacodynamic reaction. The heroin that he was using is a narcotic, right? And it has a potential to depress the respiratory system, right? So really common response to things like opioids is it depresses your respiratory function. You just stop breathing, right? Or your body's not uptaking oxygen the way that it normally does, even if you appear to be breathing, right? So it required an emergency response. I'm mentioning that to you because you will have many patients that you're taking care of who, guess what, are on opioids as a way to treat the pain that they're experiencing from the trauma. Pretty much everyone that you're bringing to x-ray from the ER is on some form of pain control, right? Watch their respiratory function. We looked at pulse oximeters, and we talked about watching breathing rate, right? All of those things are significant to make sure that they're not in respiratory depression or respiratory distress, right, from that medication. So that would be a pharmacodynamic discussion, right? It had nothing to do with this manager's age, gender, weight, whatever, right? The medication, that drug, was affecting normal physiology of the body at that point, right? So that's pharmacodynamic. So it helps me to put it in context of real world kind of crazy situations for me to see why I'm not splitting hairs here, right? All right, so drugs that produce a specific action, right, and promotes a desired result is we will call an agonist, right? And a drug that attaches itself to a receptor preventing an agonist from acting is called an antagonist, right? And you'll see that one of the areas that we see this in, particularly like agonist versus antagonist, and finding medications that don't counteract each other, is like in the treatment of depression. There are certain treatments for depression that are serotonin reuptake inhibitors, right? They are acting in a way that, if I understand this correctly, is antagonistic. It is not allowing serotonin to be uptaken by the neuroreceptor, right? Then there's other medications that may counteract that. They would be more agonistic medications that may be creating more uptake by serotonin. All right, this slide is really crappy on this thing. It should be a little bit better on your thing, but this is in our textbook on page 230, thank you. And it just kind of lays out different types of effects of medications, right? Different types of effects of medications. Okay, I would encourage you to follow along on page 230 as we're talking about this. So you'll notice that there's these different effects of medications here, and it's spelled out in a little bit more detail in the text itself. But if you're looking for just kind of some basic kind of block points or important sentences, we have it here. So therapeutic effects largely are defined as the purpose of the medication, right? And it's a drug that's going to have some kind of an action like a pain relief, blood pressure. It may help deal with infection or inflammation. Those would be considered therapeutic effects. Side effects are those things that typically happen as a response to the medication, right? Like dizziness, lightness, diarrhea, those types of things, right? Normally not a helpful thing, right? But it's how the body's coping with the therapeutic effect. Toxic effects would be things that are very dangerous, right? So in the example that I mentioned earlier, a toxic effect of heroin, for example, is respiratory depression, right? That would be a toxic effect. Another example with, for example, contrast agents is nephrotoxicity, kidney failure, right? Can be a toxic effect. Idiosyncratic effects. I said that that's the one that we want to kind of watch for. And we've already talked about how there's some subjective things here. Like the one lady, she said the contrast made it feel like she wet her pants. The next person said it made them just feel warm, right? That is what I would call subjective, right? It varies with that person. An idiosyncratic effect is something that varies in a way that I can't necessarily predict. It could be a subjective thing. It could be something to do with the physiology of the person at that time. It could have to do with their emotional state. I'm not sure. But the response is something measurable, right? So I cannot measure how much this individual felt like she wet her pants. That is subjective, right? There's no measurement for that. But there is a measurement for how many hives an individual has. There are 5 hives now on the patient's arm. So is that an allergic reaction or not? This is where we are in a significant gray area. So the American College of Radiology, their most recent Manual of Contrast Administration, has clearly stated that a contrast reaction is idiosyncratic in nature. Our textbook makes the mistake of calling it an allergic reaction. It is not a true allergic reaction for the reasons outlined here. On page 231, an allergic reaction occurs when a patient has been sensitized to an initial dose and develops an allergic response to the allergen. Their body starts to attack itself in response to the presence of an allergen, right? What's weird about contrast, and the reason that we are saying it's idiosyncratic, is you may have hives the first time I give it to you. If it was a true allergic reaction, I would expect you to go into full-blown anaphylactic shock if I give you a second dose. But what happens with the second dose of contrast is nothing might happen. You might have full-blown respiratory distress, you might have nothing. So it's idiosyncratic. There's no way to predict it. It's kind of a coin toss which day it's going to affect you, right? Now it is linked to the presence of people who have a large number of allergies, but it's also linked to things like anxiety, right? So it is very complex, is what I'm telling you. And you do need to understand this very complex process, because if you're working in a facility and you're injecting contrast, guess what? It is now clearly within your role to understand this very complex thing. So, again, to go back to that very first slide, you do not need to be a pharmacist, but you do need to understand drugs, right? And this is the one that you kind of are tasked with understanding the best. Going on down, though, we have the allergic response, and then the final thing in here is a synergistic response. And this is where a medication, when you take 2 different medications together, they kind of have a different effect when they're taken together, right? They have a synergistic effect, or they have an added effect. I'm trying to think of an example of that I've seen. Okay, but what they have here is if we have a combination of medications for hypertension and a diuretic that can cause weakness or fainting, right? That seems like a good example. Okay. Now, for this part, so I said that we need to be able to think critically about this stuff on page 230 and 231 as it relates to idiosyncratic stuff and allergens, right? One thing that I don't think I have a slide for right now, well, okay, we do. Medication to treat allergic reactions. Good. We're going to get into that. So of this list here, the one that we need to think most critically about is medications used to treat allergic reactions, right? The rest of these, the things like antimicrobials, stuff like that, we need to have some general knowledge of these things. We need to be able to define them, but we don't necessarily have to know them to the depth that we need to know that first one. So let's talk about that. Generally what we're talking about is antihistamines. The most common one is Benadryl. So I can't even pronounce this generic name of Benadryl. That's crazy, but the trade name, like what it's been given by the manufacturer, is Benadryl. So we use this a lot. We like Benadryl in hospitals. It's super helpful. It helps most people calm down when we give it to them. It has a sedative effect. And it can be given orally, or we can use it prior to giving people an IV contrast, right? Now, I just said that an IV contrast reaction is not really a true allergic reaction. But interestingly enough, we can treat it or pre-medicate for it with Benadryl. There's still debate about why that's the case, right? Is it just helping people relax? Is it actually blocking an antigen that we can't at this time find? But we have a really good outline on 231 of what an Benadryl or allergy contrast pre-medication would look like. And this protocol looks almost exactly identical to every protocol I've ever asked patients to follow for pre-medication. So there will be something like this in the department. If you're working in a department or you're at a clinical facility where they're doing IV contrast, you're calling up the patient, they say, hey, I've had a reaction to it back in the 80s. Okay, let's use Benadryl, right? And we'll follow these rules here. An oral dose of 25 to 50 milligrams for adults, right? And we will give that to them at a period of time prior to the exam, right? A lot of times it's stepped out. Sometimes they double down with some prednisone right prior to, like an hour prior to the actual exam. In the event that a patient is in what the textbook kind of wrongly calls an acute allergic reaction, I would call this an acute adverse effect of contrast. That term, acute allergic reaction, is really kind of gone out of the literature. We may be giving them adrenaline or epinephrine, so an epi shot. This is going to stimulate the heart, because what's happening if we inject an IV contrast into someone, we inject quite a bit, right? If the person goes into anaphylactic shock, so this is like a crazy allergic reaction, like an allergic reaction gone out of control, right? What happens is the heart starts to slow down, blood pressure drops, the respiratory rate drops, their O2 sats start to drop. The body is depressing everything in order to avoid this stuff being distributed throughout its system, right? We call this anaphylactic shock. We will counteract that with epinephrine, adrenaline. It causes the heart rate to accelerate. It's a vasoconstrictor, so the blood vessels constrict, and their blood pressure should rise after that injection, right? So that's what this is talking about. A kind of a borderline life or death situation. If it gets worse than that, we may be talking about what it mentions as solumedrol. I've only seen one case where solumedrol was used in response to an IV contrast adverse reaction, and the patient didn't live. So if you're at the point where solumedrol is being used, it's kind of the last ditch thing. Okay, but just know that these are generally the ways that we respond to contrast, right? Now you can probably think in the back of your mind, oh my goodness, he's talking about people dying because we gave them IV contrast for an exam, right? I am talking about that. I have seen it happen twice. One time the patient was very close to the end of their life already. The other patient had end-stage cancer and was immune compromised, had a lot of other stuff going on as well. How often do contrast reactions happen? I would say once in a blue moon. I was doing quite a lot of contrast injections because I was a CT technologist, right? If you're working as an X-ray technologist, you may not be working with contrast that much, right? What are the benefits? So the risks are pretty significant, but the benefits are we're able to do that much more detection, that much more evaluation of what the disease is that's going on. So I'm not trying to scare anyone. I just want you to understand there are medications designed to help. If you're working in a facility where you're giving up contrast, it's not something to be done lightly. Make sure that you're following the protocols that are there. They exist for a reason. Okay, moving forward. So that was the one kind of critical thinking piece to that. I would definitely encourage you to reread this section here on page 231, medications to use to treat allergic reactions, with the understanding that with contrast, it's not purely an allergic reaction. But these other things we just kind of need to make flashcards about. So antimicrobials, the number one that we use is betadine. It's the betadine scrub that turns your skin brown or whatever when we scrub it on. Also antibiotics would be in that category, so Z-Pak. Anticonvulsants, these are used to prevent seizures. An example of this would be Valium. Now, Valium can be used to prevent seizures. Once a seizure is occurring, Valium's not going to be as helpful because Valium generally is given orally. And if a person's having a grand mal seizure, which, by the way, that term has changed as well. I don't think we refer to it as a grand mal seizure anymore. But if they're having a seizure of that nature, an oral medication is useless at that point, right? It is not going to be helpful. It's going to be a significant choking hazard, right? But on the front end, to prevent seizures, Valium can be used. Now, I'm very much a strong proponent of basically everyone who gets a CT scan getting a dose of Valium before the CT scan. And the reason is because in the 10% of the population that could potentially have a seizure after receiving IV contrast, Valium has been shown to pretty much knock that out, right? Plus, Valium just makes everyone more funny and more interesting. So, anticonvulsants can be your friends. You see, we will use Valium for other things as well, but it is initially designed as an anticonvulsant. Antiarrhythmics. These are used to treat chronic cardiac arrhythmias, and that's pretty much all I will say about them. What they're doing is in the name, and an example of this would be things like lidocaine, actually, and quinidine, but I have not seen as much testing done on that concept. Analgesics, we do need to know a little bit about. These are things that are help to relieve pain, generally without causing loss of consciousness. So this can be everything from controlled narcotics, like the heroin that I was talking about earlier, to things like over-the-counter medications, like aspirin, ibuprofen. I almost feel like you should be giving this lecture at this point. Like I'm sure you're bored out of your mind. But just know that they do have potential toxic side effects. In fact, I'm doing an article right now on liver transplant, and there's a lot of liver failure linked to abuse of ibuprofen. So it's significant, especially if a person's drinking alcohol plus taking ibuprofen. Really bad idea, right? So they can have potential toxic side effects. You'll notice that our textbook, just a sec. It has an important kind of critical thinking piece here after discussing how complicated the term controlled substance is. So controlled substance is a legal term. It's a legal classification of drugs, right? And so we have like Class A, Class B, I don't know, whatever, Class C, controlled substances. Like I cannot go to Walgreens, for example, and buy LSD, correct? Yeah. I don't think they're selling that yet. Eventually maybe cannabis, something like that. Are you selling cannabis yet?
No.
Okay, good. All right. I was just curious. Okay, see, I know that's out there. Even Ben & Jerry's, I think, is selling that stuff now. I saw they're making an ice cream flavor that's that. But things like cocaine, marijuana, LSD are considered controlled substances, even though every drug that I just said has a different type of action, right? Like marijuana's a depressant, cocaine is the complete opposite of a depressant, right? And LSD, that came from an alien planet, where reptiles live and worship the sun. So all of them are very, very different, right? They're all called controlled substances. You'll notice it's listed under analgesics. Those are not all analgesics. The one that we need to worry about right here is the one that says opioids act by depressing the central nervous system. That should scare the hell out of you when you read that. Right? And we may all know someone who's been affected by that. Like it freaks me out when I hear about these Skittles parties or whatever, right? Like I lived for a while in Utah, which is considered Happy Valley, right? Happy Valley because there was more Prozac prescriptions in this one part of Utah than anywhere else per capita in the United States of America. And even then, like teenagers were starting to abuse their parents' medications. So what are we talking about? Oral opioids, things like hydrocodone, Vicodin, Percocets, right? We've all heard the rap songs on the radio and stuff, right? The Percocet one's pretty poppy. But the problem here with these things is this respiratory depression piece, right? And the reason I'm stressing it again is you've seen how a pulse oximeter works, right? We all had a chance to clamp the paper clip on the finger, right? That's something to watch if you've got a patient who's on morphine, etc., and you're transporting them to the X-ray department. You need to be watching that. If the oxygen saturation drops below 95%, the patient, you should ask them to respond. Are you with me? Wake up. Take a few deep breaths, please. Speak loudly to them so you make sure that they hear you, because they are off in la la land. Like literally Christopher Cross's Sailing is playing in their mind, and all they think is just they're surrounded by sunshine and dolphins. So wake them up. Take a few deep breaths. If their O2 sats continue to drop, get them the hell out of the department, right? Because there's a significant respiratory distress thing going on, and you need to notify the physician immediately, all right? So it's even got a little purple box with an exclamation point that I put a star by. It's important. Okay, sedatives and tranquilizers. These have a quieting effect or cause people to fall asleep. So again, there's Valium, right? But as well as lorazepam. You'll notice 2 benzodiazepines are listed in this. So we all know the song like Elton John's Benny and the Jets, right? That's what it's talking about, the abuse of benzodiazepine, right? Little cultural side note there. At low doses, these will not impair mental activity, but at a high enough dose, the person basically becomes comatose. They cannot respond to questions, not even with slurred language or anything like that. So you should not be asking them to sign forms or anything like that at that point, because they're not going to be, you're laughing, but you will be dealing with these patients, right? The effects of this drug, so we talked about how certain effects are syncretic. The effects of this drug are enhanced by things like alcohol, right? So taking this drug with alcohol can cause even more slowed reactions, and so we should be aware of that as we're working with patients. You'll notice that dosage for these drugs vary also according to age. So if a person is under 50, 2 milligrams of Valium, for example, may not have the effect on the same person now that they're in their 70s, right? It can have a more pronounced effect with age. All right, antagonists. So we said that these are used to counteract the effects of other drugs, such as sedatives and analgesics, right? Narcan's probably the big one, right? That's the final pill that you get to take at the after the Skittle party, right? Is Narcan. Well, it won't be in a pill form. It won't be pleasant. But it's basically there to counteract the effects of those other drugs. Another common one is things like charcoal. Like the first autopsy I ever witnessed, the person's stomach was full of charcoal, because it was like the last thing they tried to do to get this girl back was pump her full of charcoal, and let's see if we can counteract the effects of all the drugs that are in her system. All right, local anesthetics. You will use these, or at least facilitate preparing them, right? So when you're preparing a sterile tray for like a injection, a myelogram, or maybe like a drainage placement in CT, you may use lidocaine. You may say xylocaine there on the bottle. But this is helpful in alleviating pain in a specific area, right? So just know that it's one that we do use quite a bit. Lidocaine has some other uses as well, but it can be used as a topical anesthetic. Paralytic agents. These are kind of as scary as they sound, but these are things that may be given to a patient prior to placing an endotracheal tube, right? So you have a trauma patient who's come in, they do not have good airway, they're in respiratory distress, so we need to place an ET tube. They will give them a paralytic and cause total muscle relaxation prior to trying to place that tube, right? And so I don't imagine that you'll be working with any of those medications. Hypoglycemic agents. So there's quite a bit here, and I pretty much underlined this whole thing, but the big word to underline and note is metformin or glucophage. And it has a whole family of medicines, like it has got extended family that just keeps going. Like, do you know what's all the different forms of metformin? I can't think of what. There's metformin, metaglit, glucovance, blah, blah, blah. Just, there you go, yes. Thank you. And what are they used for? What? Blood sugar for type 2 diabetics is what I understand. Type 1, it's insulin. Type 2, the glucophage family, or metformin. Those are important because they may cause an interaction with IV contrast, right? And our textbook even mentions some stuff. We'll look at it later on. There is still debate about it. There's some controversy about how exactly to work with the patient who's on glucophage when we're giving them IV contrast. So put a bookmark in that. We'll be coming back to it and rediscussing it. But we do need to understand these hypoglycemic agents because they work in tandem with kidney function. So a large part of how diabetes is mediated works between the pancreas and the kidneys both, and glucophage is in that area in terms of its effects and potency. General precautions. Just so you know, pretty much anything that we put into a patient can cause some form of allergic reaction, right? Some patients are not allergic to barium, because barium is pretty much an inert substance, but they might be allergic to the flavoring that we placed in the barium, right? Some people may not be allergic to, for example, the water-based contrast that we're using, but they're allergic to the coloring in the crystal light that we use to flavor it, right? So we can be dealing with allergic reactions with just about anything. So know where the crash cart is. When you do the survey of your department, know where that crash cart is located and how to call a code in your facility. That is it for medication information.